My name is Scott Glaser. I practice outside of Chicago. This is a subject that I've written articles on and book chapters, and I've lectured at our national meeting and multiple state meetings, including this one last year. I've been told that I'm a little bit Bernie Sanders-esque about this. I'm very passionate about it. I'll try to ease it up a little bit and just give you the facts, okay? I have nothing to disclose on this. I just want to give you a couple of anecdotes. You can read this. You can read it on your app. These are actual cases, either published or unpublished, of patients that suffered some sort of spinal cord infarction, either the whole spinal cord or a conus infarct following a simple transforaminal epidural steroid injection. I'll just let you read through that. So last month, I got two more as an expert witness because these articles, I get sent cases to review. And in 1 month, I got two more cases to review. Received it past month, a 75-year-old with left L2-3 transforaminal. I just read a little bit about him. Active guy, immediate onset of paraplegia secondary to a lower thoracic spinal cord infarct. Second case, 34-year-old, he's had one transforaminal already, getting the same transforaminal using the safe triangle technique in 2016. Again, student, engaged, living with his fiance. Now he is paralyzed, related to a simple transforaminal epidural steroid injection, which I think all of us do fairly routinely. I don't want to assume that. Does everybody do a transforaminals in their practice? Yeah. They work. They're great. I remember learning about them in the 90s. It's fantastic. So these are folks suffering benign pain, long lifespan, some longer than others, seeking, relief for their pain. That's all it is. And these doctors are well trained. I mean, the two doctors I just looked up whose cases I got, well trained doctors, fellowship trained, board certified, and they were using the technique that they were taught in their fellowship, and that continues to be taught around the country. So now these patients are permanently disabled with no hope of improvement, and I just find that unacceptable, and I'm trying to get people to stop using the safe triangle. It's simple as that. And so let me just provide the information of why this is happening, why I believe it can be prevented. I don't want you guys going down to your radiology department and seeing this, okay? It's a swollen cord after a safe triangle induced paraplegia. So right now, I think it's actually 22 cases in the ISASS. That society, I just found another article about a conus infarct following a transforaminal. I didn't change that. I'm now aware of 17 other through medical legal reviews and personal communications. And when I've given this talk at our national meeting over the last couple of years, 5 members of the audience came up afterwards and told me that they had paralyzed patients with safe triangle transforaminals. So the reason this is occurring is that the blood flow to the thoracolumbar spinal cord is contained in a singular artery, although it can be two. There can be more than one artery of Adam Cabbage. The radiculomedullary arteries, all of them, including the artery of Adam Cabbage, are always in the anterior superior foramen. These are facts, okay? You can't argue with facts. The artery, this big artery, has been found at every lumbar foramen on the left and the right in cadaveric and studies and MRI imaging studies. And safe triangle transforaminals are causing spinal cord infarcts. A known unknown. We don't know, in each of your patients, you don't know where that artery is. You have no way of knowing that unless you're going to get MRIs and CAT scans and angiograms before you do your procedure. And that's obviously not something we're going to start doing. So whatever framing you're in the lumbar spine could have that artery in it. It's just a matter of chance. Unknown unknowns, we don't know what the mechanism of injury is. That's the big controversy. That's why people keep trying to save the safe triangle. We don't know if it's vascular injury or if it's embolism. The conventional wisdom up to this point has been embolism, but there's a lot of evidence that it's not necessarily embolism, and we don't have good evidence that it is. So it persists. Is it the embolism of steroid particles, or is it vascular damage and occlusion? Well, there's a fail-safe solution. Since we don't know which one it is, just avoid the blood supply to the spinal cord in its entirety. So every time you do a safe triangle, you are possibly placing the blood flow to that person's spinal cord in jeopardy? You don't know. So it's just a matter of chance. I mean, we don't do, very few people do cervical transforaminals anymore because of the risk. ACIP doesn't teach it, but it's a matter of chance. The safe triangle is the same thing. A little, you know, the percentages are lower obviously, but you always have the possibility of paralyzing a patient when you go in the safe triangle. The good news is that in the lumbar and thoracic foramina, unlike the cervical, we have an alternate approach. In fact, Dr. Data just showed it, the Kambin's triangle, which does not endanger the blood supply to the spinal cord. It's the root cause of spinal cord infarction. The location of the triangle mirrors the intraforaminal location of the arterial supply to the spinal cord. I had this drawn. These are all those pink, red colors are all locations of the arteries been found, traveling around the waist of the vertebra from the aorta, and I'll have better pictures coming up, going underneath the pedicle on the top of the nerve root, becomes invested with the nerve root, and then heads up the anterior to anastomose with the anterior spinal artery. And that's exactly where the safe triangle is, right beneath the pedicle. And this is a lateral view just showing where it's found. It's been found as low as the top of the disc, and it's been found as back as far as the mid-pedicle in the superior aspect of the foramen. This is a safe triangle foramen. I'm just showing it to you. A safe triangle epidural. It's the same. That's right. We're talking about right where these arteries are, and the needle's right where those arteries are. And that's a lateral view. Again, arteries going around the waist of the vertebra and going into the superior anterior foramen. And here's another issue that should impress all of us, is that why do these infarctions occur? So we're talking about these arteries in the foramen. The outer diameter has been measured, and the range is 0.8 to 1.3 millimeters. Inner diameter ranges from 0.63 to 1.03 millimeters. Outside diameter of a 22 gauge needle is 0.72 millimeters. So in other words, there's going to be some arteries where the internal diameter is smaller than the 22 gauge artery. It's not possible to cannulate something that's smaller than your needle. And these arteries are similar in size, and in some cases, like I said, smaller than the needle. And these arteries are subject to injury. It's unavoidable. Vascular damage and occlusion, muscle spasm from the trauma, clot formation, intimal flaps occur following needle penetration of any arterial wall, and in these small arteries with small open interior, it's even riskier. So the embolism of steroid particles, again, that's the conventional wisdom, and a lot of us still operate off of that. So in my personal experience, I taught it used to be ISIS, it's now ISI. I was an instructor. I'd performed thousands of these different transforaminals at all levels. And in 2001, I did a typical transforaminal. Everything looked great. I went back to do a dictation, and before I sat down to finish my dictation, I was told by my nurse, your patient can't move her legs, and she was paralyzed. So preparing for the case and reviewing the literature and the anatomy, I and my expert witnesses, including Frank Falco, concluded the safe triangle technique itself was fatally flawed. So we co-authored a first case report in 2005. At that point, prior to 2001, there were no case reports in the literature. Before we published our case report, there was a couple in the literature. Nothing much changed. Dr. Shaw and I co-authored a root cause analysis in 2010 that was published in Pain Physician, again reiterating the need to abandon the safe triangle. And this controversy distracts from the reality that both causes can be eliminated by just making sure you don't get your needle near the artery, ever. The inferior foramen is the only location for performing these procedures that completely avoids the spinal cord blood supply, and that's called Kambin's triangle, which we just saw in the previous talk. They've never been found in this area in any of the studies, and I'll show you a few of the studies coming up. It's a surgical zone, as we just saw, used for endoscopic discectomies. It was used for those procedures long before the safe triangle transforaminal was invented. Personally, with the folks I know run into at the meetings, I'd say that over half the IPM doctors, and in fact, at the meeting in Florida in 2018, it was about 50-50 who was using infraneural Kambin's triangle and who was using the safe triangle still. The infraneural approach, Kambin's triangle, is very easy to switch to from the safe triangle. The adaptation of the technique is very simple. There's Kambin's triangle. It's going to be underneath that exiting nerve root. My hypotenuse is the lower aspect of the nerve root. Again, there's the range of locations of artery adamocavage. This is a Kambin's triangle transforaminal. In the inferior foramen, obviously I'm going to show you the best picture of all. I mean, beautiful dye flow. I mean, you don't always get that. Just like you don't always get it when you do the safe triangle technique. This is Murthy's study. He's at Mayo Clinic. I've discussed this issue with him. He showed the locations of the, using MRI, I believe, showed the locations of the artery adamocavage. It's always there. It's always underneath the pedicle, somewhere behind bone. If you're behind disc, you're going to be safe. If you're getting in up near the bone, you're getting into the area where the artery is always found. This is a cadaveric study, again, just showing the size of a 22 gauge needle compared to the artery in the foramen. I mean, really, you really want to mess around with somebody's blood supply when your needle is going to be almost as big as that artery or bigger. This is a great article by Lydia Gregg, American Journal of Neuroradiology, using flat panel CT, angiotomography. Our articles were cited in it. Lydia Gregg, she's also a medical illustrator. She did these pictures, beautiful pictures showing the locations of the arteries in the anterior superior foramen. This was what she came up with, she and her co-authors, of where that purple, that violet area, that's their suggestion of where to do the transforaminal epidural steroid injections. You can see that big red circle is the mean location of where the artery adamocavage is found, the radiculomedullary arteries, I should say, but all those little red dots are all the locations they've been found. And that was the conclusion they came up with, the co-authors: avoiding needle placement in the superior half of the neural foramen, specifically the anterior superior quadrant where the safe triangles, can reduce the risk of spinal cord injury during transforaminal epidural steroid injections. I had her draw this for me. This is the Kambin triangle approach. You do the Kambin triangle approach, you're always going to be in that purple area rather than up where the artery can be found. This is interesting. You know, so I say there's 22 cases in the literature. I'm aware of 17 others. They presented this work at as I told you, she's a medical illustrator. They presented this work at the medical illustrators meeting and were contacted afterwards regarding the value of the paper due to the frequent need for medical illustrators to produce illustrations for medical malpractice cases involving the neural foramen. These are all transforaminal cases that are causing spinal cord damage. There's a lot that, I mean, they're not sending everyone to me. They're sending them to people around the country to review. The invention of the safe triangle, the stated purpose, I mean, I think it was drawn up on a napkin by a couple of doctors: avoiding the dura, avoiding the nerve root, avoiding the disc. There's never any mention of the vascular content of the foramen in the diagrams, the descriptions, or the lectures by any of the originators of the technique. And I'm old enough to remember all of this. So whenever you switch techniques, there's unforeseen consequences, right? There's going to be things that you just can't predict, or you can try to predict. Well, everybody says, well, wait, there's where the disc is. I don't want to go where the disc is. What if I puncture the disc? Well, the risk of a disc puncture doesn't have the morbidity that interrupting the blood supply to the spinal cord does. I've been doing this since 2005. I've never had a discitis with this procedure. If I do get a discitis, it's treatable. I mean, with antibiotics. Worst case scenario, patient has a fusion. But that morbidity pales in comparison to a spinal cord infarction. Failed safe triangle technique modifications: local anesthetic test doses, live fluoroscopy, digital subtraction imaging. Dr. Candido has published an article where 2 of these modifications were used and patients still became paralyzed. They're all based on the flawed but widespread assumption that it's the embolism of steroid particles causing occlusion, and we don't know that for sure. And the hypothesis being that one can, behind all those modifications, that you can cannulate the artery blindly. You can't see it, you're doing it blindly. that you can detect the uptake, abort the procedure, and save the artery from injury, and and don't embolize the steroids. This is just not a tenable assumption based on the similarity of the artery and the needle size. They don't reduce risk, and to me, they give a false sense of confidence. I mean, they don't work. There's been case reports in every single one where it didn't work. They do not prevent direct injury to the artery, causing occlusion of the artery. They do not prevent arterial wall injuries, traumatic aneurysms, intimal flaps, thrombus, vasospasm, even transection. I mean, you could put your needle right through this artery. In some cases, it's small enough. Now they're non-particulate steroids. Again, it's a technique modification. And I'm stealing a little of Dr. Candido's thunder here. The only reason the way a non-particulate steroid is going to work is this mechanism of injury is embolism, and therefore it's destined to fail. We don't know the mechanism of injury. And my concern is the transition to non-particulate steroids, since they tend not to last as long. I know we could argue about that, but in my experience and talking to people around the country, they don't last as long, so these people are going to end up having more needles put in for more injections, or deciding to have surgery earlier than necessarily they need to, and there may actually be more paralysis cases because we're doing more safe triangle transforaminals because it doesn't last as long. Evidence, there is really no evidence for non-particulate steroids. It was promoted by multiple societies, not ACIP, in a letter to the FDA, and their logic was, since there'd been no spinal cord infarcts yet, that was one reason they felt that's robust evidence. And in a pig brain study, non-particulates injected into the vertebral artery, into the carotid, did not cause a large ischemic area, whereas particulate did. And this is a different situation. I mean, putting a needle in a carotid artery versus a needle in a very small artery. The FDA at that time reviewed all the evidence and convened a hearing with multiple physicians, including myself in 2014, and Dr. Candido presented as well. They did not see enough evidence to recommend it against particulate steroids at that time. This was printed in ACIP's Pain Physician, our periodical. Just look at that sentence. I mean, this is just what we're saying here. Replacing particulate steroids with non-particulate dexamethasone might avoid an embolization event, but it would not avert injury from a needle trauma, dissection, or spasm of the artery. I mean, this is what our national organization published. Again, the range, I keep showing you the range of locations. The use of the safe triangle technique should be abandoned due to the risk of injury. Until we can prove that that's not a mechanism of injury, I just think we got to abandon it. And I don't want to sound like Bernie Sanders, but I just feel very strongly about it. And this is Lydia Gregg did this for me. There's the safe triangle. There's an artery going in. Again, look at, that's a great picture. That's the average size, average. Not the, I mean, there's one smaller than this. That's the average size of the artery down there in the bottom. And there's a 22 gauge needle in comparison to that artery. Do you really want to be putting a sharp bevel needle near that artery? It gets fixed in the dural sheath, so it's not just floating around there. And this is what could happen. You get complete transection, vasospasm, thrombus, intimal flap. This is just me showing a technique for doing the infraneural Kambin's triangle approach. It is more difficult at L5S1, but it can be done. You just go outside the SAP, touch the SAP if you want, put it right behind the disc. You'll see it just inside the shadow of the SAP. Injection of dye flow, again, very good. It's not always that good. These are videos. You said they would work. I don't know how to activate them. So this is for L4-5. Again, just showing the needle placement. Sorry about putting my head in there. And advancing parallax view down the needle. Again, you can touch the SAP. You don't have to. Can you start that one for me, please? L5S1. So often I'll go down and I'll just barely touch the disc. You can just feel it back up a little bit. That's enough. You can go ahead. And so if you want to look at these, there's just some more videos. So I want to give special thanks to Dr. Shaw. He's not here. The 2010 article, I hope you guys get a chance to read it. Remember, above all, our duty is to do no harm as physicians. Those are my contact information. Feel free to contact me anytime.